Hey, it's me, Jen again, and welcome to Save Your Thyroid. Today's guest is leading a Thyroid RFA revolution. We'll talk to Dr. Nikravan after this. One thing I hear on the regular is that patients are sick and tired of feeling sick and tired after thyroid surgery. Dr. Nikravan was no stranger to hearing this comment from his patients. Eager to offer them a better way, he adopted Thyroid RFA as a treatment option for thyroid nodules, and his patients couldn't be happier. Let's talk with Dr. Nikravan about his wins in the world of thyroid nodules and RFA. I've heard so many wonderful things about you from patients in our Facebook group. You know, the fact that you are one of the few providers that have done over 100 RFA cases is quite impressive. Just recently, we've been told by one of our group members, you're one of the first to do a case of a cancer that was over 1 centimeter. So you're absolutely blazing a trail here, sharing your successes on YouTube even. And I just want to know what has driven you to be such a pioneer in this area of medicine.
You know, when I finished my training at Harvard UCLA, we went to the Endocrine University at Mayo Clinic and to train for ultrasound and ultrasound-guided biopsies. So I figured that if you want to be a thyroid specialist and an expert, you really not have to understand the physiology of the disease, but what you really have to understand is the anatomy and the radiographic findings of the thyroid. So that would give the patient a very comprehensive approach. So our practice dating back to 2003, it became 2005, it became very comprehensive. So the patient came in with a thyroid problem. We not only mentally thought about the disease process, but then we became radiographically involved in it too. So we were able to offer ultrasound-guided thyroid biopsies as early as 2005 to all the practices, at least in Southern California. We were the pioneers of that. Over the years, we've done over 50,000 of these guided biopsies, and we stopped counting. And then not too long ago, we said, you know what, we got to take this to the next step and, save the people's thyroid. Because as an endocrinologist, what we see all the post-op complications of surgery that the surgeons don't follow, they don't really see. Nothing against surgery. We love surgery for patients that qualify for it. But if you could offer an alternative, minimally invasive procedure for a patient that they can save their thyroid, because I don't care how much thyroid hormone you give a patient, it is never going to be the endogenous production of their own gland, which T3, T4 hormone regulates the TSH, the pituitary. Certain days it produces more hormone versus it produces less hormones. That's why patients get such fluctuations on the thyroid hormone. We figured that why not take the next step and the leap and invest into the procedure and take the procedure, because it's been very gratifying to see the patients. It has been so ungratifying to see my patients to go to surgery, to come back with either vocal cord injury, damage, or resection of the thyroid, because surgeons are very aggressive. They just take out the thyroid. So what? You take a pill every day. And my thing to them is like, do you know how hard is it to take one multivitamin a day? I cannot stay consistent. And now you're telling the patient they have to stay alive to function well. You give that medicine that can interfere with other drugs, absorption, delay time. This is why we decided to go the thyroid radiofrequency ablation route. And so you know what? We have heard my patients for 20 years. I'm tired of hearing the same complaint over and over again. What are we doing differently? So we decided that it is the best thing to offer our patients another option besides surgery, and that's how the thyroid radiofrequency ablation came apart over a year ago.
That's incredible. What an amazing perspective on it being just that you're sick and tired of seeing your patients be sick and tired. That is right in line with what I hear from patients all the time is I'm so tired of my doctor not understanding what I'm going through. I know a lot of patients will appreciate hearing you say that. With your experience in this area, what are some non-negotiables that patients should be looking for when they're looking for a physician who offers this procedure, thyroid radiofrequency ablation? What would you look for if you were yourself a patient?
Well, the interesting thing is the thyroid radiofrequency ablation should be offered by physicians who have been doing ultrasound-guided thyroid biopsies for at least a decade, if not more. Because you have to be very comfortable with the ultrasound, you have to become a radiologist and actually an interventional radiologist. I remember when I started the thyroid ultrasound-guided biopsies, even though I was certified back in 2005, there was a big learning curve. At that point, we had done over 150, but when I started my own practice, I still had reservations. 20 years moving forward, I look back at that 20-year-old endocrinologist that he was younger out of the practice. I was like, you know what? I would never touch a radiofrequency procedure because you have to feel so proficient at the anatomy of the neck. You have to be so proficient at doing the biopsy and so proficient in having no complications. Knock on wood, I'm going to say it, we've never had a complication. We've done over 50,000 ultrasound biopsies since 2005. It's very different. As a surgeon, you're very proficient using your eyes and your hands on the thyroid, on the gland, and it's very complicated. I'm not going to belittle surgery. Surgery is not straightforward. Complications take place. But as endocrinologists who are not surgeons, we don't have the luxury of opening up the neck. So we have learned over the last 2 decades to use ultrasound-guided imaging. It's like robotic. You go look at the image, you put the needle in a small little place, you get the samples, you cause no harm, no damage, you come right out. So we have learned, because since we can't open up someone's neck, to actually do radiofrequency and ultrasound and biopsy based on ultrasound imaging. So I believe that this procedure should be done by physicians who are very, very accustomed to ultrasound-guided biopsies, who have been doing it for at least a decade, who have had several hundreds of biopsies in their belt. We stopped counting at 50,000, and who are comfortable with it too. I think that a great surgeon is a surgeon who's been practicing for a very long time. I always say, when I send a patient to an endocrine surgeon or just a general surgeon for a thyroid surgery, I make sure that these surgeons are extremely well qualified and have had done hundreds of cases. Because I want the patients, when they come back to us, I don't want a parathyroid problem. I don't want calcium problems. I don't want to deal with patients who have scar tissue and surgical clips and staples. I get these emails. I mean, we get so many complaints regarding these things. That's why some of us are the pioneers of this radiofrequency. We're so eager to move forward with this to save our patients' thyroid, because it's a very important gland.
Absolutely. I hear all the horror stories from patients about how so many doctors just think of it as a vestigial organ that's just disposable.
No, absolutely. When we first started the thyroid radiofrequency, there was a very nice patient, lovely girl, and she wanted to get radiofrequency, but her insurance wouldn't cover it.
Right.
And I said, you know what, for the nominal cost of your thyroid for the rest of your life, you're in your 30s and your 40s. You should get the procedure done. And I can't tell you, she's written me 4 emails. She did the surgery. She's written 4 emails to me ever since last year, and every email is a cry email. And she's so sad with surgical clips, complications. That's one of the many emails we get. I tell the patients, like, you know what? It's a very small little investment to protect your thyroid, and I would do it. It's extremely important.
The difference between how satisfied patients are with surgery versus the radiofrequency outcomes. And, you know, with patients primarily having this done on benign nodules, are there any features that you would say are not obvious for contraindications? You know, we know that patients need to have 2 benign biopsies and that they need to have ultrasounds that show benign features, but are there any not obvious contraindications that you would say benign nodules have for RFA?
So when we look at thyroid nodules, we look at their size, number one. Then we look at their color, characteristics, echogenicity, border, calcification, shape, their morphology. There are so many things, and that fits into a thing called a TIRAD system. And based on the scoring system we give these patients, we say the likelihood of this nodule being benign. Because with ultrasound, I would say with 75, with 80% of the cases, you can be very, very sure that what the ultrasound looks like, if it's benign or not. And sometimes you can be fooled. But usually the patient comes in, has a very benign looking nodule, it's compressive. You know, we do a biopsy. Usually they say do 1 pass. We typically do between 4 to 6 passes if we're going to radiofrequency. Because if the nodule looks benign, we try to get the maximum samples on the first hit. Because then we can decide the patient. For those nodules that are slightly of any concerns, they get 2 biopsies, 2 separate occasions. And we do between 4 to 6 passes to maximize the samples. The other thing we look for is vascularity. And then we look for lymph nodes to see is there any lymphadenopathy. Because sometimes we picked up thyroid cancer just based on looking at the lymph node. And that's the most important thing we look for. But the criteria set for the thyroid radiofrequencies are very clear at this point. There's no peculiar unknown criteria.
Well, what about in cases of thyroid cancer? What would be an indication that you would say makes a patient a candidate for RFA if they have a thyroid cancer?
So right now, the data that came out of South Korea, Mayo Clinic is going to publish their data. We're collecting our own patients, our own subpopulation data, is that right now, the thyroid radiofrequency procedure is really good for thyroid patients, papillary thyroid cancer, were 1 or less than 1 centimeter. We did a case not too long ago. We just did another one, 1.3 centimeter. So you want to make sure, number one, the thyroid nodule is well accessible to the radio frequency, that the borders are clear. So when you radio frequency this nodule, you have to make sure you not only radio frequency the nodule itself, you have to be able to radio frequency its borders. I can't tell you the number of patients I turn away for thyroid cancer to come in with 3.5, 4 centimeters. They wanted this done. They're begging to get it done. I would love to do it, but the criteria is I have to be able to get clear borders. If I cannot get clear borders, I cannot cure the case. And the most important thing, we look for the blood supply. We try to destroy the blood supply. In the case that we did on a patient, it was 1.3 centimeter. I was able to hydrodissect the nodule off the trachea, a very sensitive area. And at that point here, we radio frequency the entire border outside first and worked our way inside. Because if you radio frequency the very obvious, the problem is you can no longer see the borders. So it's crucial that the person who does it understands the anatomy. And at this point here, we're not advocating to do nodules more than 1 centimeter, but it's very case individualized. We had a follow-up with our patient. The blood supply to the nodule is gone. The nodule is decreased by 15 to 20%, and it's going to continue to decrease. And the blood supply went from extremely hypervascular gland to completely avascular, which is no blood supply. So we look for those things. But to answer your question, we want something a little bit 1 centimeter or less. We want it somewhere in the thyroid. We don't want it next to the vocal cords. But again, those things can be looked at individually.
Excellent. And when you have a case of someone who has had their thyroid nodule removed surgically, it was benign, and then afterwards they found out that this nodule actually did have some cancer in it. And I suppose there's no way to know once you've treated a nodule with RFA, would there potentially be any consequences to that if you treat a nodule that's benign and then, somehow you were able to determine that after the fact? That's kind of a roundabout way to ask that question. But the patient that brought this up said there are cases where benign biopsy result is discovered to be cancer based on histological post-op findings. What happens when RFA is applied in this situation? And again, I don't know how you would even know, but I just wanted to ask the patient.
So the best way, I always tell my patients ask this question. I'm going to give you two cases. Patients come in and they say, you know what, I have this thyroid nodule and I want to get the radio frequency, and then what are the chances of its regrowth? Well, the chance of regrowth is extremely nil to none if the nodule is fully treated. The most important thing patients need to understand is that you want to treat the nodule when it's smaller. You don't want to wait for the nodule to get big. The treatment plan works so much better when the nodule is small, and you can radio frequency a smaller nodule much easier and with much better results than waiting for it to get bigger. Because if there are margins and there are areas that are untreated, theoretically, those untreated areas can grow again. And theoretically, the untreated areas can possibly turn into malignancy down the road, theoretically, but we don't know that yet. So in reality, if we take a nodule and we treat it, and we treat a radio frequency very effectively, the chance of that turning into thyroid cancer is like, can you bring the dead alive? No, you can't bring the dead alive. But what you could do is you could destroy the nodule, and sufficient destruction of the nodule with the appropriate treatment of the borders should not allow the nodule to come back. That's why we do the follow-up in 3 months and 6 months and 1 year. And as a matter of fact, we're doing a case tomorrow, very lovely, a patient that was actually a patient from a different organization that came here, and she is getting a radio frequency on her lymph node. And she had thyroid cancer, and her thyroid cancer was resected, and they said, oh, don't worry about it, don't worry about it. She has this lymph node. She's in her mid-30s, and she found us, I'm not sure through social media or where she found us, and I looked at her neck, and I said, I don't feel anything, but let me just get an ultrasound because we do it in the office. And I found like a 3.5 millimeter lymph node on her right side of her neck, in the level 3 of her neck. And I said, that looks really suspicious. It's, it's got the classical suspicious characteristics of malignancy. Let me put a needle in it. She goes, oh no, her endocrinologist said we should not do it. It's no big deal whatsoever. And I put a needle in it, and I think I posted it that this needle should be biopsied, and it was papillary thyroid cancer. She's on the schedule tomorrow to undergo the radiofrequency ablation of that lymph node. It's very straightforward. You put a 5 millimeter probe dead center of that lymph node with ultrasound guidance. You turn the machine off, and in a matter of, I would say, probably 5 to 7 seconds, you can ablate the nodule very effectively. And this patient does not have to redo neck surgery because her neck looks good, the CT scan looks good, the CT PET scans look great, and that's one little spot. That little spot could be the seed for recurrence of thyroid cancer in a 30-year-old patient. So again, this is an amazing technique. We love it. It's great for our patients. Anything that can minimize the risk I mean, could you imagine a 30-year-old to redo neck surgery, the complications, the lymphadenopathy, the drainage, the damage, the scar tissue, the downtime? Oh,
That's absolutely a case I would not want to have to undergo surgery more than once. That's terrible. I'm so glad that that's an option for, I didn't realize it was an option for treating lymph nodes as well.
it is. It is for med cancer, and actually insurance is paying for it. Insurance is paying for it
Excellent.
because they realize that redo neck surgery will probably be anywhere between $60,000 to $70,000, depends on where they go. And so with this patient and the advocate, it was very easy to get that covered.
Excellent. Excellent. Do you see any applications for RFA outside of this, like hyperparathyroidism or Graves' disease?
If the patient has toxic multinodular goiter, we've done 15 cases already out of the 110 that we've done already. And that's a perfect case. For Graves' disease, not yet, because Graves' disease is a uniform disease. So it's kind of hard. That means you pretty much have to treat the entire gland. Theoretically, if you go in there, you destroy 65, 70% of the gland. But what about the remainder of the gland? The remainder of the gland can have hypertrophy, regrow again. Maybe as a temporary method, I don't know. We've never done that before. I'm not advocating for that either. But for toxic multinodular goiter, it's a perfect remedy. We're doing 2 cases tomorrow for toxic multinodular cases too. And they're traveling, one is traveling from abroad, one is traveling from Northern California to get the procedure done. And so it's a great procedure. And especially if they're younger, female, why would you want to give these patients radioactive iodine?
No.
And destroy their thyroid and destroy their eggs and their ovaries in a young, healthy, childbearing patient? The treatment protocols have to change. And so that's very important too. We are ready to take on these cases. That's excellent.
I think that the long-term thinking is what's important here. You know, so much of the time when you see these younger cancer patients, it's like clearly no one's thinking long-term here about when this patient down the road may get married, want to have children. They're not thinking about any of that. And it's just such a shame and such a tragedy. Let's talk about voice changes. We have had, unfortunately, a very small number of patients in the Facebook group experience this. One patient asks about sensors being used during the procedure to protect the voice. Can you comment on that and describe the measures that you take during RFA procedures to protect the patient's voice?
Actually, I think maybe the same person emailed me, wanted the procedure done, wanted the voice sensors, and we don't offer the voice sensors.
Okay.
Because to offer the voice sensors, it's a little more invasive. You have to put the probes on the cords and etc. through an ENT procedure and etc. It's just unwarranted. It's not recommended. When we do the procedure, there are 2 options. Patients can opt to do it through local anesthesia, which I don't really recommend. Through a conscious sedation technique, what we do in the office, the patients have a phenomenal experience. And the reason for that is that number one, we keep them very comfortable. They are wide awake. I talk to them during the entire procedure. I ask them their name, their favorite restaurants. I even get cook recipes for them. I am talking to these patients constantly. If the nodule is in close proximity to the vocal cords or the recurrent laryngeal nerves, the increased risk can happen here. And I can tell you that that's very, very low, because if you know the anatomy, you know the structures, then you tell the patients that, you know what, you want to treat this thing much sooner before it touches the vocal cord. And those patients who have vocal cord involvement, we usually leave a margin of untreatment around that close vocal cord area. Or we use a hydrodissection technique by lifting the thyroid off the area and cooling the area as I simultaneously heat the area through that technique. So I'm not only injecting the dextrose cold or D5 into the area as I'm doing the procedure, just to cool the nerve. We do that aspect of it. Sometimes when you cool a nerve, the nerve gets stunned too. But the stunning that takes place should be temporary. It can last as early as 30 seconds to 3 minutes to 3 hours to 3 to 6 months. But in the cases that we've had, they're all resolved. And we've had 2 cases in the 110 patients with the procedure, and they all resolved. One resolved in 30 seconds and one resolved in 3 months. So it just takes and where it goes from there, and it's very, very impressive. And again, it's about the limitation of the procedure. That's why I say get those nodules treated, and your operator needs to understand exactly the location of the nodule and its proximity to that nerve.
So you're a big advocate for treating early when things are not to the point of compression?
Absolutely. Absolutely. It's a no-brainer. You know what? You want to get this thing treated because you can get anywhere up to 99 to 100% reduction versus 60% or 50% reduction. Because the larger the nodule is, you have to keep in mind that it's close to the trachea, it's close to the danger triangle, it's close to the recurrent laryngeal nerve. And the closer you are to those areas, you want to stay away from those areas on purpose. So you'll leave a margin of untreatment just for safety precautions, when you're dealing with a 5 or 6 centimeter nodule.
And I've got a question from a patient about the combination of PEI with RFA. Do you have thoughts on the best way to address nodules with a large cystic component?
PEI is old and outdated. We used to do PEI. PEI is, okay. So first of all, PEI is extremely painful. It's like shooting alcohol into an open wound. Very, very painful. PEI can cause vocal cord damage, hoarseness. I've had that before. We have done so many large compressive cysts, as long as a nodule has cystic component and some solid component. So what we have devised a technique in the practice, we've done it so successfully, and nodules are almost 95% cystic, almost 100% cystic. What we do is we put a needle, simultaneously we aspirate, if it's recurring really quickly, and simultaneously, as we aspirate the needle, we collapse the capsule. Through the technique, what we do is we radio frequency the lining of the capsule together. We glue it shut, and we do it for all cysts. Because of the success of the procedure, we stopped doing percutaneous alcohol.
Wow, that is incredible.
Because you know what? Percutaneous alcohol does not destroy the cyst. It just kills the lining and cyst stays there.
Hey, thank you for that explanation. I've never heard that before. I hope that other physicians will adopt that practice. That sounds really revolutionary. Well, I know that our time is up. I cannot thank you enough for giving me your thoughts on all these issues and for taking the time to speak with me. And I just want to applaud your diligent work in promoting this procedure and helping patients to save their thyroids. Keep up the good work. Keep on posting those YouTube videos. And I just want to thank you from the bottom of my heart for what you're doing for patients.
Well, I want to personally thank you as a patient advocate, for someone who has experienced this. You know, your advocacy, your love for the patients, your love for your colleague patients is impeccable. Because if it wasn't for you, these people would not know about it. And it's your voice and your hard work that brings it out. And we have to team up together to allow the patients to know. And you'd be surprised to know physicians don't even know about the procedure, and they're still sending them to surgery. So it's a social media, it's the searches on Google, it's your voices, your efforts, our efforts put together, which brings about awareness. So I want to thank you.
Well, thank you very much. I appreciate that. It means a lot to me to hear that from someone with so much influence in this area of medicine. It really means a lot, and I'm just very grateful for what this has done for me. And I can't shut up about it, and I'm not going to.
You should. We feel the same thing too. On our end, similar to you, we have now offered our site to be the training center for physicians across the country. Now
That's
the
excellent.
Thyroid Institute of Southern California, so we're now training physicians all across the country who want to learn about the procedure.
Well, I hope many will come out there and get trained. You know, I'm hopeful that right now we have 70 physicians in the U.S., and I'm hopeful that number is going to double in 2022. Stay tuned for that.
Absolutely.
Thank you so much for watching. You can help others tremendously by sharing this content. Never forget to educate yourself and be your own health advocate. Now, watch this next video right here.